This is a 66-year-old female who presented with complaints of palpitations and apprehension after a few days history of gastroenteritis. Now what we can see, this ECG is showing something which is pretty obvious. So this appears to be a run of tachyarrhythmia. So there are lots of causes of tachyarrhythmia. Now one important aspect of diagnosing a tachyarrhythmia is obviously how it looks like, the shape, the morphology, the rate. But one more important aspect, and whenever you are able to see that, always look very carefully on that, and that is the tachy onset. So we can see this is the QRS complex, and then there is this beat coming, and then we can see a run of tachyarrhythmia. Now it's a very broad and very bizarre kind of tachyarrhythmia, and there is no fixed coupling interval, so it's very variable in morphology, in rate, and even axis as well. So this beat most likely triggered this arrhythmia. So what happened was that, if we can see that the arrow is pointing to the onset of this tachyarrhythmia. So preceding that, we can see this is a QRS complex, and then this was a huge T QT interval that was kind of coming up till over here, and the next QRS complex is landed on the end of the T wave, and this somehow managed to trigger this arrhythmia. Now, which arrhythmia is usually seen when this phenomena occurs? So this is called an R on T phenomena, and with a long QT, there's a possibility that there are some ventricular ectopics that come on because of early after depolarization. So these ectopics can, if they land at appropriate time on the T wave, this can trigger a VT. Now there are two types of VT. This is most likely a polymorphic VT, as described earlier, that we can appreciate these broad, bizarre, and changing in morphology and axis. So this was a case of a polymorphic VT that occurred in the history of long QT because of most likely hypokalemia due to gastroenteritis. Now, the polymorphic VT has some variety which is called Torsades depointers. So first of all, let's describe the polymorphic VT. So the polymorphic VT shows a gradual change in the amplitude, and there is not a fixed axis. So this axis keeps on changing. So if we can see that, if this is an upright QRS, and then over here it comes down negative, and then again it comes positive. So you can see it was a kind of changing in the axis on the baseline. So this is called Torsades D points, and because of that, the patient is kind of a very high risk for developing into ventricular fibrillation. So these arrhythmias are usually self-limiting, but these have a very high chance of degenerating into ventricular fibrillation. So always be wary of these arrhythmias, and don't confuse them with other VTs which are usually monomorphic and scar related. So it would be fine on the ECG. The polymorphic VT should have a beat to beat variation in the morphology as being shown. The rate, the ventricular rate usually ranges around from 150 beats, and even can extend up to 250 beats per minute. And when this polymorphic VT occurs in the settings of long QT, then this is called Torsades depointers. So these Torsades usually terminate spontaneously, but they can somehow go into VF. So now this was the ECG that was preceding this episode of arrhythmia. So this was the same patient few minutes before. So we can see now there are two things going on. One is the bradyarrhythmia, bradycardia actually, because we can see this is the heart rate, the ventricular rate is so kind of very bradycardic. So this is less than 50 beats per minute most likely. And one thing more is the QT. So the QT also kinds of look a bit prolongish. So these two factors are very important when you kind of manage the patient after diagnosing it. So now let's move forward. So there are some pearls which are associated with these arrhythmias. So usually the torsades, they come in the runs of paroxysms, which means that few beats will come at a very fast rate, and then they can completely vanish away, or sometimes they can even degenerate into VF. So whenever you see a few runs of 5 to 20 beats of such a faster heart rate with variable morphology, then always be wary that this patient might go into some dangerous life-threatening conditions. So this will be a change in polarity of QRS. There will be a complete 180 twist of the QRS complexes in just few beats. And usually the onset occurs with a short, long, short sequence, but this is not always the case. But usually the pattern, the common pattern is a short, long, short sequence. And any torsades that occurs in the setting of a quiet QT is usually preceded by uh, pauses. So this means that when there's a long QT and the pause, just like we have seen before, there was a bradycardia and the long QT, be wary that this is now the trigger for torsades anytime. So always try to manage and preempt these torsades before this happens. So what are the etiologies for that? Very, very common causes, as you can see in your clinical practice. So anything ranging from electrolyte disturbances, hypokalemia and hypomagnesemia, such as this patient was actually having both hypokalemia and hypomagnesemia, and that triggered this long QT, and also followed by this arrhythmias. Drugs, very important drugs. So antiarrhythmics. So you know that that antiarrhythmics, again, they themselves are the cause of arrhythmias. So which antiarrhythmics, when you give them, you always try to look for these, that these might be one of the causes for that. So you might need to stop them or change to other alternative. So these drugs include class 1A, class 1C, and class 3, just like as sotalol. Antibiotics, so many medical patients on the medical wards who are having these infections, that they are giving very common antibiotics, just like azithromycin or erythromycin or even levofloxacin. So these can cause long QT, and again this can cause torsades. Antifungals, antihistamines, anticonvulsants, and even the cardiac diseases. So don't forget that myocardial infarction itself can cause long QT and bradycardia, just as we've seen in our case. So you can see these are very, very important causes. So always try to look out for each of them whenever you find such patients. So even correcting these can totally clear away all these arrhythmias. So the treatment, obviously you have to treat the underlying cause. So if there are drugs, stop them or change to some other drugs. If there is electrolyte disturbances, definitely you have to manage them and bring them to the normal level. And if the patient is having bradycardia because of even drug induced or degenerative or due to anything, so if the QT gets prolonged and there's a bradycardia, you just need to do pacing. Just put in a temporary pacemaker for a short period of time unless you find out the cause of this bradycardia. So QT interval shortens with a heart rate which becomes faster, and when you treat this bradycardia. So in some congenital long QTs, like in some few children who are having these polymorphic VTs because of long QT, that is congenital cause of channelopathies, then beta blockers should be given. So the beta blockers, they are very important drugs, although they should be avoided in bradycardia. But if there is no bradycardia and it's just long QT, then they should be given. And finally, if despite doing all the things you cannot manage this with all the available options, then ultimately you have to put in the implantable cardioverter defibrillator, because if you cannot correct any reversible cause, just like in congenital QT, and the beta blockers are not doing their purpose well, then ICD is indicated, because these arrhythmias can go into VF anytime and just give few seconds to manage this patient, obviously, and these can be life-saving in majority of such patients.